Hello, welcome to MedSchoolCoach's sample tutoring session. My name is Andrew and I'll be leading our session today. I will explain our tutoring framework and present a sample lesson. MedSchoolCoach has three main approaches to tutoring that is individually tailored to each student's needs. These include content-centered sessions, Q&A sessions, and question bank coaching sessions. In our content-centered sessions, we provide high-yield interactive PowerPoints. Unlike other PowerPoint presentations, these are very dynamic and require active participation. Some slides will show schematics of pathophysiology, while others might be a blank table that you and your tutor fill in together. Moving on to our Q&A sessions, these sessions are a two-way street of questions and answers. Students can ask their tutor to clarify any topic they have a difficult time understanding. Other times, tutors will probe their students' knowledge in order to fill any other unseen holes in their understanding. This is particularly useful practice for your MS3 and years beyond, as many attendings and residents like to use this style of teaching during rounds. Lastly, we offer question bank coaching sessions, where the student and tutor go through Q-bank questions. This provides an opportunity for our tutors to help students identify trap answers and build their test-taking technique. Students will have the option to review questions they have gotten wrong or new questions they have not yet seen. In addition to our three main approaches, we offer optional sessions that can be added to any session. First, we can end our session with student teach-back summaries. This helps solidify the material discussed over the past hour. And secondly, we can provide a 5-minute session refresher at the beginning of each new session that revisits topics discussed in previous meetings. That concludes our brief introduction to our tutoring styles. We will now transition to a sample lesson on heart failure, which encompasses our three main approaches to tutoring. Recall, every lesson is individualized to each student's learning style and areas of weakness. Therefore, the distribution of time spent on questions, slides, and Q&A will differ for each student and each session, depending on their preference. Through this sample lesson, we hope that you will find that MedSchoolCoach is the best fit to help you achieve your learning goals. Hello, Renee. Nice to hear from you again.
Hi, Andrew. Thank you for having me today.
Yeah, so we're going to be talking about heart failure today.
Perfect.
So let's get this started with a question kind of to frame this whole thing. So I'll start reading and we can kind of go through all of the potential answer choices. So a 64-year-old man visits his primary care physician because of worsening shortness of breath over the last 3 years. He has a long-standing history of untreated hypertension and had a right-sided myocardial infarction last year. He states that he requires 4 pillows to sleep on and occasionally wakes up at night gasping for air. His temperature is 37, blood pressure 168/101, pulse 95, respiratory rate 18. His exam reveals an S3, peripheral edema, and an elevated JVP. What is the primary mechanism for this patient's edema? So, what are your thoughts? Any initial impressions?
Well, I'm definitely concerned about heart failure in this patient because of his history of MI and his symptoms that are very consistent with heart failure, including the JVP, peripheral edema, his S3, and also his symptoms that he has. So I would be concerned about his contractility. To me, I don't think it would be increased because he probably has a poor contractility. So I think I would mark D off the list.
Perfect. Excellent.
Okay. Vascular permeability, that's usually something more having to do with some kind of vascular disease. I don't see how that kind of comes into this question, so I would mark that off the list.
Perfect. That's great.
An osmotic gradient, I would think of something more like high protein state or high glucose state in the blood. So there's some kind of osmotic gradient going on, and that doesn't seem to apply here.
Perfect. Yeah.
Hydrostatic pressure does not seem to apply as well. And if anything, it could be increased. So I think my answer here would be decreased cardiac contractility.
Perfect. That's exactly right. So I liked how you went through each one and understood kind of the whole physiology. And by doing that, you're able to get the right answer. And I liked how you did process of elimination to confirm that you got the right answer. So you're correct. The answer is definitely a decreased cardiac contractility. So now we'll go through a little bit of physiology. just to make sure we have kind of the basic understanding for all of these. Do you remember what preload is?
I don't remember exactly what defines it, but it's basically how much the heart fills before it pumps.
Right. So it's kind of everything that's how much is in it before it pumps, exactly. So basically defined by how much is filled. Do you remember what afterload is?
That's what's remaining, or that's what it pumps against.
Right. So it's like the resistance it pumps against. And then do you remember what contractility is?
Kind of like the squeeze of the heart.
Right, exactly. So how hard the heart squeezes. Now, do you remember any of the like maneuvers or things that might be able to increase or decrease preload?
Venous pressure is one. Would that increase it?
So if you have more venous pressure, right, and then do you know any maneuvers maybe that would be able to increase that?
I'm not sure.
So a couple ways you can do it is you can do a leg raise. So this actually, because gravity kind of pulls the blood back to the heart, you get like a 250 cc bolus to the heart. So this is a very easy way to increase your preload. And same thing with rapid squatting. So when you rapid squat, you kind of compress all the veins in your legs and it does the exact same thing. So that's how you would increase the preload. Any thoughts on how you might be able to decrease the preload?
I'm not sure.
So one way you can do it is you can stand really fast. So this way, when you stand really fast from squatting, all the blood that kind of was being able to be pushed up because of the muscle squeeze now there's nothing left. There's no squeeze left. So then rapid standing is going to decrease your preload.
Okay.
Another couple things you can do is you can do the Valsalva. That'll increase the intrathoracic pressure and prevent the blood from returning to the heart. And another thing you can do are diuretics. And by doing that, you'll basically pee out any of the volume that would normally be in your veins.
Okay.
And then what about afterload? Can you think of anything that might increase it?
No.
So one thing that can do it is a squat. So when you squat, you actually compress your femoral arteries. And when you compress the femoral arteries, your heart has to squeeze much harder because now the lumen is basically much narrower in your femoral arteries. So that'll increase your afterload. And then a hand grip basically will do the same thing. And then any thoughts on maybe how you would decrease afterload? It's more of a medication and less of a maneuver.
Like antihypertensive medications?
Right. So particularly in this case, we'll say nitrates. A bunch of other ones definitely do as well. So anything that affects the afterload, anything that affects the systemic vascular resistance, definitely. And then contractility. Do you know anything that increases contractility? These are less going to be maneuvers and more just kind of different states of the cell.
Calcium. If there's more calcium in the cell?
Right. So if there's more calcium in the cell, definitely calcium will increase contractility.
And I know that there's drugs that push more calcium, but I don't remember which ones they are.
Yeah. So here's one. Digitalis is definitely one. So digoxin, digitalis is a drug that we can use to increase contractility. Other things that might be able to do it is if you have catecholamine surge, especially with beta-1, or anything that causes decreased sodium extracellularly.
Okay.
And then any thoughts on decreasing contractility?
Decrease calcium?
Yeah, pretty much. Decreased calcium, that would be one of them.
I'm not sure.
Yeah, so no problem. So you can get beta blockers. So this way it'll block the beta-1. You'll have hypoxia, because this way now your heart has no oxygen to kind of develop the ATP that'll cause the contraction. And also calcium channel blockers, kind of a medication that will directly affect the heart.
Yeah, that makes sense.
Yeah. Well, great job. So then here's another slide. I'll send you all of these slides after we finish so that you can have them. We'll go through cardiac anatomy real quick. So this is what the heart normally looks like. You kind of know where everything is going based on your anatomy. But let's say you have hypertension. What's going to happen if you have long-standing hypertension that you don't treat?
Your left ventricle is going to have to work harder.
Right. Anytime a muscle works harder, it gets bigger, right? So that's what we
Right.
see here. So the problem is when you get left ventricular hypertrophy, do you know what you are at increased risk for?
I'm not
Increased risk of
sure.
two things. One, you're going to be at increased risk for ischemia. The
Okay.
reason,
Yeah.
the reason why you're at increased risk for ischemia is because now the concentration of blood vessels in a certain area, like a per square inch area, is now much more dilute because you have so much more surface area to cover. So then now you have a much higher risk of developing hypoxia in those particular areas. And
Okay.
another thing is you have a higher risk chance for arrhythmia. Do you know why that might be?
I'm not sure.
So remember, your conduction pathway is very well organized, right? So it kind of starts here, and then it'll progress across, and it'll hit the AV node. So SA node to the AV node, and then it's going to go perfectly down his Purkinje system. But now, because the LV is so much bigger than it normally does, this conduction pathway looks a lot more disorganized. Now it's confused about where to go. So now you're at a higher risk of arrhythmia. This is the two main reasons why having LVH, left ventricular hypertrophy, is dangerous. So let's go through a little bit of the heart failure pathology. So our patient in the beginning had hypertension, and then we think he has heart failure, right? And we said that the primary thing was that he had decreased contractility.
Mm-hmm.
So with decreased contractility, you can get a couple of things. We'll basically start with decreased cardiac output. What do you think happens when you have decreased cardiac output? Maybe, let's say, with sympathetic activity. Do you think sympathetic activity goes up or goes down?
It's going to go up.
Yeah, so sympathetic activity is going to go up because now your body thinks, oh no, I'm bleeding.
Right.
And then what about your renin-angiotensin-aldosterone system? What do you think a decreased cardiac output is going to do?
That's also going to go up.
Right, so then your RAAS system is going to go up. So if your RAS system goes up, what's going to happen to kind of your sodium and your water reabsorption?
That's also going to increase.
Right, so then you have to reabsorb more water and more sodium. Now this is going to increase your systemic venous pressure. If you have increased systemic venous pressure, what's going to happen to your preload?
It's going to increase?
Yeah, preload's going to go up. The
Okay.
problem is, it's not that we have a problem with preload, we have a problem with how hard we can squeeze. So then once you keep overloading and overloading and overloading, the ultimate reality is that you increase the preload so much and eventually fall off the Starling curve, and then your cardiac output continues to worsen. Another thing that decreased LV contractility causes is increased pulmonary venous congestion. What symptoms do you think you can get if you have this?
Coughing, shortness of breath.
Yeah, cough, shortness of breath. And this is going to be from pulmonary edema.
Uh-huh.
And then now that you have increased pulmonary congestion, do you think your right ventricle has to work a lot more?
Right, yes.
Right,
Yeah.
so then the RV is going to have to work a lot more, which ultimately means that the RV output is going to decrease. And this here is why you get your peripheral edema.
Mm-hmm.
Excellent.
Okay.
So this is a little bit about the basis of heart failure pathophysiology. Everything's pretty much connected. One other thing I forgot to move here is that increased sympathetic activity actually also increases the RAS system. Everything that basically is designed in your body to think when you're bleeding, you got to hold on to everything, kind of falls into place here, but actually is part of the issue for heart failure.
Mm-hmm.
So we talked a little bit about the clinical features of left heart failure. Can you tell me kind of the main three?
Peripheral edema.
Left heart failure. So
Oh, sorry.
Yeah.
So shortness of breath?
Shortness of breath, maybe is there any particular time also when they have shortness of breath?
Like when they're sleeping?
Yeah, do you know what that's called?
Orthopnea?
That's called, so when they're sleeping and they wake up, that's called paroxysmal nocturnal dyspnea.
Oh, okay. That's right.
But then when you're sleeping, you're oftentimes lying down, right? So then if you get short of breath when you're lying down, what's that called?
I'm not sure.
So you had it a second ago, it's orthopnea.
Oh, okay, so that one's orthopnea.
Right.
Okay.
So this is waking, short of breath. But then this one is short of breath when supine.
Okay.
Excellent. And then, so if you have long-standing left heart failure, we kind of talked a little bit about it. You get the backup of the pulmonary veins, and then now there's congestion. Your right heart has to work so much harder than it used to. And eventually you might end up with right ventricular dysfunction and right heart failure as well.
Okay.
So the ideal is to kind of hopefully prevent all of this from happening, because the most common cause of right heart failure is left heart failure. And it just keeps backing up.
Okay.
So let's talk about the clinical features of right heart failure.
So that's where peripheral edema would fit in.
Exactly.
Okay.
Anything else? These other two.
Would JVD also be there?
Nice. JVD, absolutely.
Okay. I'm not sure on the third one.
So the last one is going to be kind of in between. So you have kind of the neck, and then you have the feet, and the other one you have is hepatomegaly, kind of right in between the two.
Okay. That's easy to remember.
Perfect. So those are the three main features of right heart failure. Very important to know. And let's go through a little bit of Q&A. We'll just kind of go through these really quickly. Do you remember what the equation for cardiac output is?
I think it's stroke volume times, I don't remember.
Nah, it's okay. We'll get you there. So stroke volume times heart rate. That's what you get to cardiac output. Okay. So it's stroke volume is how much you pump per beat. Heart rate is how many beats per minute. And cardiac output is how much you pump per minute.
Okay.
In the terms of units, we can get that. In terms of what circumstances do you think blood viscosity is increased and decreased?
I'm not totally sure.
So, yeah, no, sorry, go ahead.
Could heart rate affect it?
That's a great thought. Unfortunately, the blood viscosity is kind of a property of the blood itself. So anything that kind of surrounds the blood, so like the pump itself, will actually not affect the blood viscosity. So it's something within the blood, like you have
glucose or proteins.
Protein.
Okay.
So high protein states.
Okay.
Anything else you can think of?
I'm not sure.
So you can also have high red blood cell states.
Okay.
So anything like polycythemia is going to be very viscous. So like you said, protein and red blood cells will both increase viscosity. And then what about decreasing viscosity?
Low red blood cells and low protein.
Yeah, there you go.
So anemia.
Exactly, anemia. A lot of times, I actually had a patient one time who, when he came in, he had hemoglobin of 2. It was so, like, when we drew his blood looked like red Kool-Aid. It was really, really had low viscosity. He actually ended up having hereditary hemorrhagic telangiectasia, but looking at the tube of blood was very profound to see low viscosity. Let's see, the third question here we have is the mechanism of action of digoxin.
So it's going to increase calcium flow into the cell, the cardiac myocytes?
So it's less going to increase the flow into the cell but rather it's going to prevent the calcium from leaving the cell. So
Okay.
the primary mechanism is it actually inhibits the sodium potassium ATPase. And by doing that, you keep the sodium levels in the cell very high. There's a
Okay.
sodium calcium co-transporter as an exchanger. The goal is to try getting the calcium out and the sodium in. But because the sodium is so high in the cell, this doesn't work very well. So the calcium in the heart cell stays very high, and the contractility ends up increasing. That's the main mechanism of digoxin.
Okay.
And then lastly, do you remember the pathophysiology and EKG findings of Wolff, Parkinson, White?
Not really.
So you have your heart here. And then normally, we kind of talked about how your conduction goes from the SA to the AV node. Well, there's actually in this an accessory pathway. This is called the bundle of Kent. And what happens is the depolarization, instead of going through the AV node, it'll end up going through this accessory pathway. When you get is a very interesting and unique EKG. You get something called the delta wave. Do you know what the delta wave is?
It's like a little wave that comes before the P wave on the EKG.
So it actually comes right before the
Q wave.
the Q wave, right?
Yeah, that's
the
right.
QRS complex. So it's basically this thing right here. It's supposed to go up much more profoundly, but now there's a delay here. And then what you'll end up having is a wide QRS. The reason why I have a wide QRS is because the conduction does not go through the normal His-Purkinje fiber system, or rather it might go retrograde instead of anterograde like normal. This will cause delayed conduction.
Okay.
And you'll also get a shortened PR interval, because now instead of going from the P in the atria through this rate limiting step of the AV, you'll end up going through this accessory pathway, which is much faster. So you're going to get your ventricular contraction much before your normal. So that's why you have a shortened PR interval. Any questions on that?
No, I think that makes sense.
Okay.
What are some of the symptoms of people with Wolff, Parkinson, White?
Yeah, so sometimes patients with Wolff, Parkinson, White can feel, usually it's a younger person actually, they can have symptoms of palpitations in their heart. They can sometimes feel anxiety. They can have shortness of breath. But it sometimes kind of looks like a panic attack. But patients typically will do just fine. All we have to do when we treat it is get rid of this accessory pathway. You can go under and you can basically just ablate this whole thing and the heart works just fine.
Okay.
All right, and let's just go through a couple more questions and then we'll call it a day.
Okay.
All right, so it's the exact similar patient. So this whole presentation is the same. The only question is maybe what other physical exam findings would you expect?
Okay. So we think that this guy probably had, so he had a right-sided MI. So,
Right.
and he's got symptoms of right-sided heart failure. So he's gonna have other symptoms maybe of right-sided heart failure.
Right.
Do
you think he also has left heart failure?
I think he probably does have some left heart failure too, since he's had untreated hypertension. And you said that the most common cause of right-sided heart failure is left-sided heart failure. So that could have been the inciting event for his right-sided heart failure. So kind of want to look for symptoms maybe of left-sided heart failure. So he could have some pulmonary edema. So maybe he could have the lung rails.
Yeah, this could be it.
Papilledema
Going through the other answers just to make sure.
is usually a sign of increased intracranial pressure. So I don't see exactly how that would fit in. I'm not sure what C is actually, so I would kind of ignore that one. Cyanosis, maybe if he was having very, very, very poor cardiac output, but he seems to have, I mean, he's able to move around and everything, so probably not cyanosis.
That's correct. Yep.
I'm not sure what the positive whisper is, so in this case, just knowing what I know, I would probably go with the lung rails.
And you would be absolutely correct. So like you thought, he has pulmonary edema. So there's a very good chance he has bilateral lung rails. So Quincke's pulse, just for future reference, is a sign of aortic regurgitation. What ends up happening is you can press down on the nail bed, because the heart has to pump so hard and is very hyperdynamic in aortic regurgitation, you'll see the pulse actually kind of push into the nail bed. So you'll see kind of the area where when you press into the nail bed, there's like an area of flushing, and you'll actually see that area of flushing move on every single heartbeat in aortic regurgitation. It's a very impressive finding.
Wow.
And then positive whisper pectoriloquy, this happens when you have lung consolidation. This is because sound moves better through solid objects. And when you can have patients either whisper like A, B, C, 1, 2, 3, and then you'll listen to areas of the lung.
I remember learning that in first year.
Yeah, so actually clinically relevant.
Yeah.
Yeah, so sometimes it's really hard because during the first couple years, you don't know what is actually going to impact your patient practice. And I think it's a good way to remind you that this is actually like all real, you know, it's not fake. So a really fun time. All right, great job on that question. Let's go through this next question. So basically the same patient again, but they did an echo and they found that his ejection fraction is 20%. The question is, which of the medications has not been shown to improve mortality in anybody?
Okay, so I remember that certain drugs do improve mortality for people with left-sided heart failure. I know beta blockers are one of them.
Right.
So B would not be the answer.
Perfect.
It's not been shown. ACE inhibitors are one. So that would not be the answer. I know diuretics are, so I'm going to wait for C and E because I have to think about it. Nitrates, I do believe, have been shown, so D would not be the answer. I'm pretty sure that furosemide is not shown to increase mortality, but I'm not totally sure if I remember between C and E.
If you had to put your guess on this, what's your heart tell you?
My heart would say E would be the right answer.
So E is exactly the right answer.
Oh,
so
great.
In patients who have reduced ejection fraction, usually underneath like 25 to 30%, spironolactone has been proven to actually improve mortality. I think the study is actually maybe 35%. But between 25 to 35%, this will improve mortality. Even though we use furosemide to improve symptomatic heart failure, this actually has not been proven to improve mortality in anybody. So it's just for symptomatic relief. So your gut was right. Furosemide's the right answer.
Okay.
Perfect. And last question, the exact same question, except which of the following medications will address the underlying neurohormonal cause of this patient's symptoms?
Okay. So we talked about the pathophysiology, and we talked about the renin-angiotensin system, which I think is what this question is kind of addressing, is the neurohormonal aspect of his symptoms with left-sided heart failure. So the things that would directly affect that would probably be an ACE inhibitor, since that directly affects the renin-angiotensin system. You did mention that increased sympathetic activity also increases the RAS system, but I don't think metoprolol is really going to directly affect the RAS system more than captopril. Spironolactone shouldn't have an effect. Nitrates, no. And furosemide or Lasix really shouldn't affect the system either. So I would say the ACE inhibitor, captopril.
Perfect. That's absolutely the right answer. And it's actually been shown that if you give an ACE inhibitor, you'll actually reduce the cardiac remodeling, the pathologic cardiac remodeling of heart failure. So then you can actually kind of reverse a little bit of the damage. So exactly as you said, captopril is the correct answer.
Okay.
And maybe let's just wrap up. Maybe you can just give me a quick review of a little bit of the pathophysiology and clinical presentation of heart failure.
Okay, so with the pathophysiology, you have decreased contractility, and that's going to increase sympathetic activity. And then the increased sympathetic activity will trigger the, like I was just saying, the renin-angiotensin system to kind of kick into action. That's going to increase sodium and water reabsorption. The decreased contractility will also cause backup, and that's going to cause backup into the lungs and cause some pulmonary congestion leading to pulmonary edema. That causes the right-sided heart failure because the right ventricle is going to be working harder now because of the backup in the lungs. And so that's going to lead to the peripheral edema that we see in right-sided heart failure.
Yeah, I think you got most of it. That's great.
Yeah, most of it.
And what about like if someone comes in with, let's say, left heart failure, like what are their primary symptoms? Like what would they kind of complain about?
So those we would find like what we talked about, shortness of breath with like the paroxysmal nocturnal dyspnea, orthopnea. Those would be their main symptoms for left-sided heart failure.
Yeah, that's exactly right. And what about like, say, the treatment? We kind of went through the medications on the last couple of slides.
So the treatment, we're trying to increase their mortality and then also improve their symptoms. So usually, like you said, furosemide and Lasix are a symptom medication that we use, but then for mortality, we want to use an ACE inhibitor, a beta blocker, nitrates, and spironolactone.
Exactly. Absolutely nailed it. Great job.
Okay.
Glad we were able to cover this and help you with
that was very helpful.
Yeah, appreciate your interactions and your enthusiasm.
Thank you so much, Andrew.
Yeah, of course. So this concludes our sample tutoring session. We cherish the opportunity to contribute to your journey as a physician. Every one of us at MedSchoolCoach is rooting for you and believes in you. We promise to work as a team to optimize your learning, stress levels, and overall wellness through this process. Thank you again, and best of luck on your journey.